So 25 years ago, I first heard the term psoriasis. It's the most common autoimmune disorder in the United States. 7 million people have it. And for most, it's mild. But for many, it's severe. It can cover the entire body. It can turn into arthritis. And you can live with it for the better part of your life. 10 years ago, I heard for the first time the studies starting to show that psoriasis is more than a skin disorder, which is how it manifests. It's treated by dermatologists. But it promotes systemic inflammation, which can lead to a whole variety of health conditions, heart disease, diabetes, stroke. And this actually means people diagnosed early, like I was, have 10 to 20 years less life to look forward to on average. What nobody knows is what can I do to change that equation to make sure I live long enough to see my kids grow up. And about 10 years ago, I had a stressful period. It's known to flare the disease. So not only did I have skin symptoms, but all sorts of other interesting things cropped up. Fatigue, weird cognitive deficits. And I started to look around for advice. I spent 10 years talking to physicians with no success. The last physician I talked to about this was very honest, and he said, yep, we have no idea how to help you. We don't have the tools. There's no clinical research on the symptoms that you're talking about for this disease. Sorry. Come back in 2 years, you're as healthy as a horse. And I was miserable every day. And someday I'll have my wife tell that story. But as I started looking out on the internet, there's a massive amount of things that you can find that purport to help you. I spent 1 hour on one of the larger psoriasis forums and found 40 different suggestions for treatments, from topical treatments to curcumin to changes in diet. And you'll see discussions. Diet cured my disease. It can't cure the disease. Diet, doesn't really help me. And we know that diet helps 10%. We don't know anything about diet, and that's the cacophony. And there's not a lot of organizing people in the middle of this particular condition to kind of help separate the noise and the signal. So at the same time, as Sunny is telling us, we have so many different ways to understand more about how we're doing. So how bad am I today? Is something I'm doing affecting how bad I feel, and can I do something about it? So I ran into Gary Wolf, who is one of the founders of the Quantified Self Conference, and he invited me to give a talk. And the wonderful thing about talks, they force you to think about something in a very different way than you do inside your own head. And even when you're giving it, it comes out differently than you expect. And so it can be very creative. So my PhD thesis, which I just finished at MIT, came out of 2 talks that I gave. And the second one was this Quantified Self talk. And when Gary and I were talking, I said, I do all this tracking, but I never write anything down. So I said, well, how can you track without writing anything down? And what I did was I tracked the things that were most likely to help me update my list of hypotheses in my head. I had all these different theories. And so when I thought I was going to feel good and I started to feel bad, that was a hint. So the big question that came out of that talk is, well, gosh, I have never been able to track anything more than 3 days in my life. And Sunny's going to make that a lot easier for me. But what could I gain from short engagements? What could we learn from a short period of tracking that would give me leverage and maybe other people leverage too? How do we make that data more actionable? And how do we make it something that I can bring back into the care environment? Because something we often hear is both patients and doctors are overwhelmed by all this data. So we have to put the data in context so that we can both act on it. We can talk about it in meaningful ways. Now, there's a popular topic called the single subject experiment. And much like Michael talked about, it is a formal mechanism for doing a clinical trial in one person. But when you look at doing a dietary trial, it's 6 months long. To actually look at the couple of month effect time, you have to do a treatment period where you look at the effect of the treatment, and then you have to wait a while for it to go away, and then you have to measure for a while to get a statistically significant result. So I started to explore this idea as part of my doctoral work over the last few years, and we started out just saying, well, let's document a catalog of measurements, treatments, and experiments that tie these two together. So curcumin for psoriasis. It's a simple question of, if we know a little bit about how long it takes to work, and we know a little bit about your baseline, and we measure during that period the status change that you're interested in this case, the activity of the psoriasis, then maybe you can get some handle on what's going on. And this is an example of some of the data that you can collect on systems like this, where we clearly identify a baseline period, a treatment period, and then a follow-up baseline period. And that starts to give us some confidence that the change that we introduced into our lives changed the measure that we're using to evaluate how our lives are going. But we can juxtapose that with all the other things that might have affected that measure. And this is not a rigorous N-of-1 trial because we haven't necessarily controlled for all the confounding factors. In fact, to do a rigorous version of this trial, I should repeat this cycle 3, 4, 5 times. So a personal experiment is taking the N-of-1 trial and stepping back and saying, what are we really trying to accomplish by measuring and changing things in our lives? And we're trying to transform this narrative that we get online or that we tell it ourselves into some data that we can act on in a way that we have confidence in. And this is an example of a topical treatment. It's a simple severity scale. So, if you have psoriasis, you know when it's acting up and it's not acting up. It gets itchy or it gets less itchy, and there's visible manifestations. And this is an actual trial that was done on a patient-recommended over-the-counter treatment that costs $1 a month, doesn't have long-term harm, and it gets rid of all the worst of the day-to-day symptoms. It's not a cure, but topical steroids aren't a cure either. But this is a much safer treatment than topical steroids, which is the standard of care. So personal experiments are about decision support, not proving that something is true. It's an estimate of how likely am I to benefit? What's the size of the benefit? How much do I benefit? And it's fast, it's reasonably cheap, and it's personally useful. And it gives me a context for discussing my experience with a professional. And I want to show you some examples of people collecting data that may, both in the personal experiment context, but also just more broadly. So you heard from Erin earlier today. And Erin has a wonderful blog post about taking this data from the same system into her doctor. And they were having a dialogue. Is this a bacterial exacerbation that needs IV antibiotics? Or is this a cold that's causing some postnasal drip? Well, the IV antibiotics means 2 weeks in the hospital, and we all know what that means for cost. And the other, and not to mention misery, but the other one is simply let's wait it out. So the doctor was really leaning towards the conservative choice because you don't want to let these things go. Until he saw the data that showed the variation, that documented the patient's experience, he said, oh, okay, well, let's do a 24-hour hold. And Erin can jump up and correct me if I get her story wrong. But the result is he was out of the hospital the next day, his coughing went down because the nasal steroids kicked in and dealt with the symptoms of the cold. Did you good, Erin? All right, thank you. So there's another way we can use data like this to make a case. In this case, this is a study I ran. It took me forever to get this done because I tried to do it through the traditional system. But this could have been done without any professionals involved, and it would have had the same effect. At a patient conference, a set of patients were talking about their rare disease and phenomenology, which is that their dyspnea, their breathing symptoms varied with their menstrual cycle. And it's a women-only disease. Not that much was known at the time about the role of hormones in the disease. And so the leading researcher who was interested in hormones said, is that real? How prevalent is it? What's going on with it? And I said, well, why don't you do a research study? Oh, IRBs and funding and my postdoc, and I've got all this other stuff to do that pays the bills. So I said, well, what if we could document that experience for the population to sort of lower the risk for the researcher and also to validate what is otherwise dismissed as anecdote? And this is just the population results, 3 months of 3 times daily PFT readings averaged over a whole period of time. And we found is a couple of patients that are showing periodicity. And this actually mirrored the clinician's intuition that, in fact, there is a small subpopulation of patients that show variation in pulmonary function, not just dyspnea, not the sensation, but the actual function that varies with the menstrual cycle. And that's really weird. And so nobody knows why. But it gives us an opportunity to think about it. The unexpected impact was the researchers saying that data is so stable throughout these 3 months that we had always assumed that PFT data really can't be used in clinical trials. But we don't need to bring patients in to do the big PFT machine if we can get a really stable measure just on a higher frequency. So the outgrowth of all of this, I ran into Michael and his compatriots at the C3N Project, Cincinnati Children's Hospital, and they said, gosh, we've been trying to build a system like this. Could you bring this into the care environment? I said, absolutely, love to. And so we added some population management tools for clinicians and researchers and dealt with all the HIPAA issues and applied it to pediatric inflammatory bowel disease, like the 2 girls that Michael mentioned. And we're in the middle of a study, and I want to talk a little bit about what we've learned from that study. The first thing we've learned is that essentially N-of-1 experiments, patients and doctors aren't going to do either because they take too long and they're too hard. But what can we learn while we're controlling the condition? So on the left side of the screen is a just series of post hoc trials. The patient had had a surgery to correct problems with his inflammatory bowel disease, and the doctor's convinced he can eat anything now. It's going to be fine. But for months or years, he's been suffering with any kind of food. Milk he can't eat, all sorts of things that he can't eat. So he's terrified of food. And so he and the doctor sat down and said, well, let's just do baby steps. Let's document, let's kind of see how you're doing. get a sense of where you're coming from, and then try a food and wait a few days. And if that goes well, then we're going to try the next food and the next food. And there's sort of 4 foods up there at the top of the screen, and by the time he's done, he had a little stomach flu there in the middle, that little blip. So now you've got this nice history, you know exactly what happened. And what we started finding with our early patients is that this graph here serves as a kind of two-way mirror. I put the data up there, and I can annotate a data point, I can talk about what happened during the day, and all of a sudden I'm communicating with my doctor all the time. Now my doctor's not looking all the time, but when the visit comes up, they're looking at the same thing I'm looking at. And that two-way engagement has changed the psychology of the experience. And what we're finding with almost everybody is that it takes less time in the visits. The visits are more focused on solving problems, which is what doctors are good at and trained to do, as opposed to eliciting information, education, and all the other things that you're asked to do but not given a lot of support for. The second chart is the response of a patient to a microbiome transplant. I won't go into the details of that because lunch is coming up. But the result is we have an opportunity to watch the evolution of that patient's symptoms over time. And we see exactly what we want to see. So the second measure, the little spiky measure, is the number of times a day that his abdominal pain interferes with his activities. This is a 17-year-old violin player. And when his pain is that bad, he can't play violin, he can't practice, he can't go to school. So the measure just below that is weight, which is one of the most important variables for inflammatory bowel disease, because it says your bowels are working, which means you're getting nutrition and you're growing. And so you can see he had a great response to the transplant, and that's been sustained in the months since. So we started to conceive as a group of this idea of personalized learning in the context of clinical care, and it's completely congruent with the personal experiments idea of what we might be able to do independently to generate evidence for ourselves and to share with others. So this two-way mirror is a really powerful opportunity to have a shared context around what happens between the visits, around parameters that might not be lab values, but actually are of importance to me. We have many patients who are in clinical remission and are miserable. And that's not something that clinical research gives us a lot of tools to work with. But with this, we can start to document it, we can start to learn, but it asks that both doctors and patients start to participate in an experimental process. And I think that's the really interesting challenge of the next 10 years, of how to make that something that is natural for us all to participate in. The measurement's going to get easier with people like Sunny, and I think the analysis is going to get easier as we build tools and we can get mHealth organized into making the data presentation something that we can act on. And what I'm most excited by is the prospects for starting to add up all this information. So just like we did with that population, where we started to characterize the population through patient-provided data, how many people respond to curcumin for psoriasis? We have no idea today, and nobody's doing research on it for the reasons Michael mentioned. There's no profit to be had. There's no way to fund a $2 million, $5 million, $7 million trial. And I've been writing proposals in medicine, and I can tell you, $10 million doesn't go very far at all. $10 million is a drop in the bucket. So we can do things much cheaper. You can also characterize the size of the effect. If the treatment is expensive or painful or unpleasant and the effect size is small, it's a waste of time. So we can now start to be really diligent about the cost-benefit analysis. And that allows us to feed a shared decision-making process more effectively with data. So what are the best measurements to use for this particular treatment? What are the known confounders for it? How do we avoid noise? These are all things we can learn collectively. So we go back to Michael talking about the learning health system. If we really want to learn collectively, there's so much more we can learn from point-of-care interactions, from experiments that happen at home, outside of the care environment. But we need a systematic way to think about it and characterize it and share it with one another. Thank you very much.